Hello and welcome to Pathophysiology. My name is Dr. Sheila Taylor and I will be your facilitator for BCS 210 Pathophys this semester. And so we're just going to jump right into Chapter 1. And in Chapter 1 we're going to look at the general concepts of disease. So this is kind of the introduction to what we're going to be discussing throughout the entire semester in the lecture material. Learning objectives of this chapter include being able to define the common terms used to describe disease, including but not limited to lesions, symptomatic and asymptomatic disease, etiology, and pathogenesis. Listing the major categories of human diseases. Outlining the approach that a practitioner uses to make a diagnosis and decide on a patient's treatment. Describing the various types of diagnostic tests and procedures that can help the practitioner make a diagnosis, and compare and contrast the different imaging techniques described within the chapter. So, in the study of disease, the first question has to be, what is disease? And I'll give you a second to think about it. What do you define disease as? Well, disease really is any deviation from health. How do we know we are sick? There are mornings I get up and I go, ugh, I just don't feel good. Well, does that mean I'm actually sick with a disease? Or is there maybe something else going on? How do we actually know when we're sick? What are symptoms of disease? And what are signs of disease? And there is a big difference between what a symptom and a sign is. What is pathogenesis? Well, if we break the word down, genesis means the formation, patho means disease. So how does this disease actually form? And this is really a broad spectrum term. It's basically what causes it, what's it going to do in the body, how are we going to diagnose it, how are we going to treat it, and what's the probable outcome of the disease. And then what is etiology? What does diagnosis mean? What's prognosis mean? So we'll look at each one of these. So diagnosis. This is really the determination of the nature and cause of an illness. We can do diagnosis through clinical history of the patient and of this particular disease, the physical examination of the patient, and we usually then will come up with something called the differential diagnosis, a list of rule-outs, if you will, of a potential cause of this disease. And then upon further investigation, we oftentimes will be able to figure out what the definitive diagnosis is. What actually is this disease? What is causing it? How are we going to treat it? And what's the probable outcome? So what's prognosis? Well, prognosis literally means the predicted outcome of a disease process. And prognosis is based upon the history of the disease in that particular species, the history of the practitioner with this disease, and sometimes it's just simply the best guess that we have. What is treatment? How are we going to treat this patient? What is the best treatment for this disease? Does the patient even want treatment? Or does the disease need to be treated? Specific treatment is directed at the underlying cause. If we can get rid of what's causing it, we'll get rid of the disease. Symptomatic treatment, however, alleviates the symptoms but does not influence the course of disease. We are not getting rid of the actual underlying cause. We are simply treating what the patient is feeling. What is the clinical history? When I go into the room with a patient, I want to know what is the history of the current illness. What's the severity? When did it come on? What's the characteristic of the patient's symptoms? What is the patient feeling and for how long have they been feeling it? What's the medical history of this patient? And this is the details of the general health and previous illnesses that may shed light on the current problem in this patient. I would like to know family history if I could, because does family history play a role? Absolutely. The health of the patient's parents and family members. What diseases has the patient's family had? Does this disease have a genetic component and does it run in the family? I would also like to know the social history of the patient, and this includes what's their occupation? Do they have any habits that might be leading to this problem? What is their alcohol consumption, their caffeine intake, their tobacco consumption? How's their general health been before this problem presented? And are there any other current problems that they may be having? Review of symptoms. What is the patient actually feeling? Symptoms other than disclosed in the history of the present illness may suggest other parts of the body may be affected by this disease. And sometimes these are difficult for the patient to actually reveal unless the practitioner is very good at asking open-ended questions. At some point, though, with my patients, I'm going to have to do a physical examination. I'm going to have to feel that lump that they're talking about. I'm going to have to actually put my hands on them and thump around on a body cavity or press for internal organs. So the physical examination is the systemic examination of the patient with emphasis on the parts of the body that are affected by this current illness. Abnormalities noted can correlate with the clinical history. So maybe they've had an appendectomy and you see the appendectomy scar on the surface of the skin. Now, differential diagnosis is really the consideration of various diseases or conditions that may also explain the patient's signs or symptoms. A patient comes in with vomiting. Well, what could cause vomiting? There's a whole plethora of diseases that could cause vomiting. And so I have to put on my general diagnostic list the primary diseases that I think this could potentially be. Then I have to look at those and look at the diagnostic possibilities and narrow them down by selecting specific laboratory tests or other diagnostic procedures that will hopefully lead me to then a definitive diagnosis. Opinion of medical consultants may also be sought. Maybe this is not my area of expertise and I need to send this patient to someone else who has a better knowledge in this particular area of the body than I do. So how do we choose a diagnostic test? Well, once I have the histories and the physical exam findings, I can look at all those and get a good idea of how to proceed at that point. So I could do general screening tests. I could actually go, well, I think this might be strep. Let's do a rapid strep test here in the clinic today. I need to look at, though, the cost of these tests. Is this test that I'm going to choose, or tests, are they going to be cost efficient for the patient, and is it going to give me good information? I need to look to see if the test is invasive versus non-invasive, and we'll talk a little bit more about that in a moment. Is this test appropriate for the question being asked? I could say, is this strep? Then a rapid strep test may be the exact test that I need. Does the testing procedure have false positives or false negatives? And what's the ratio? If I'm choosing a diagnostic test that has a lot of false positives and the test comes up positive, does that 100% prove that my patient has this disease? Well, the answer is absolutely not. What if it has a high false negative ratio? And so I get a negative test. Does that disprove that the patient has this condition? And the answer again is no. So some screening tests for detection of disease. Why do we want to do these? Well, for one thing, oftentimes these will detect early asymptomatic diseases amenable to treatment and prevent or minimize late-stage organ damage. The earlier we can detect the diseases in some cases, the better the outcome will be for the patient. We can screen for certain genetic diseases because if you have the genetic propensity for a particular disease, could we actually do preemptive therapies that will decrease the risk of you developing this particular genetic disease? And so we can screen for carriers of some genetic diseases transmitted from parent to child as either a dominant or recessive trait. And we can identify carriers to allow affected persons to make decisions about future childbearing or the management of a current pregnancy. Example, there is a recessive gene for sickle cell anemia in approximately 8 to 10% of all black individuals in the world. And so we could actually screen for this and see what your likelihood of passing this gene on to the next generation might be. Now, we also want to make sure that our screening tests are for groups that are suitable for the screening test. I'm not going to do prostate screening on females. It just doesn't work that way. Nor will I do pap smears in males. So I need to make sure my groups are suitable. I need to have a significant number of persons that are at risk for the disease in the group that is to be screened. I need suitable screening tests. I need a relatively inexpensive, preferably non-invasive test that does not yield a high number of false positive or false negatives and must be available to screen for the particular disease. Benefits of screening certainly is this should provide some benefit to the person being screened. If it's not, then why are we doing it? Invasive versus non-invasive. What do these two terms mean? An invasive test breaks a barrier membrane of the body. So, for example, a blood test would be an invasive test because it breaks the surface of the skin. Now, is a colonoscopy an invasive or non-invasive procedure? Well, anybody that's had a colonoscopy would think invasive. However, it's actually a non-invasive procedure unless a biopsy is taken. As long as the surface of the colon is kept intact, it remains a non-invasive procedure. So that's the difference between the two. There are several tests upon which we can choose from, and one of the most common are the clinical laboratory tests. This actually gives you a lot of information for very minimal invasiveness to the patient. The purpose is to determine concentration of substances that are frequently altered by disease in either blood or in urine. Uses can be to determine the concentration or activity of particular enzymes in the blood, to evaluate functions of certain organs of the body, to monitor responses of certain cancers to treatments, or to detect disease-producing organisms in the urine, the blood, or even the feces. And we can even use some of them to determine the response to antibiotic therapy. And this is just an example of the general blood work laboratory report that we find. And so what we'll see is oftentimes in our chemistry panel, we will actually see several different things that are monitored in the blood. And our CBC and platelets will also be looked at oftentimes in our CBC complete blood count. And so oftentimes with my patients, I'm ordering a complete blood count and a chemistry panel. Imaging. Well, what can we do to image the body? There are a number of these that we can do. Most of them actually are non-invasive. And so X-rays. And I hate to use that term because it was drilled into my head by our radiologists when I was in vet school that X-rays are not that black and white film that you see. That is radiograph. So pardon me if I use radiograph as the vernacular instead of X-ray. X-ray is what takes the picture. And so what we'll find in radiography is we use high energy radiation waves of X-rays at lower doses that produces images then to help diagnose disease. X-rays can penetrate fairly easily because they are high frequency waves through tissues, and they do so at varying degrees depending upon the tissue density. The denser the tissue, the less the X-rays can penetrate, and the wider the image will be on the film. We use a photographic film or plate, and this will be captured then as the X-rays penetrate through and leave the body. Anything that's radio opaque will appear white on the film. These are the high density tissues such as bone, which is the densest tissue of the body, and they absorb most of the x-rays, and therefore they do not pass through the body and onto the film. Radiolucent, however, means that the film will appear dark, and the reason for this is the film is exposed by a high number of x-rays that reach the film. Low density tissues such as those areas filled with air, like the lungs, will allow all of the x-rays to pass readily through and therefore will reach the film and turn the film dark in color. I apologize. My dog Bella decided that she wanted to say something to you all on that last slide, so I do apologize completely. All right, let's continue on the x-rays. X-ray can include use of contrast media to outline structures not otherwise visualized on standard films, such as barium sulfate for the intestinal tract all the way from basically the esophagus to the anus. Radiopaque oils, such as used in bronchograms, intravenous dyes, especially used to highlight structures in the urinary system, radiopaque tablets that can visualize gallstones, arteriograms, which will visualize blood flow and identify narrowing or obstructions within blood vessels, cardiac catheterization, looking specifically at blood flow through the coronary arteries in the heart and detect abnormal communications between the chambers within the heart. And so this is actually a normal chest x-ray or chest radiograph. This actually shows, again, the dark white, the radio-opaque bones. This is actually coming right down here is both the vertebrae and the sternebrae. The sternum is actually overlying the vertebrae and the backbone. Right here is the cardiac shadow, which is the heart. Here are the main stem bronchi that are branching out here into the lungs. But you can see that the lungs are much darker than the surrounding tissues. That's because they are radiolucent and will allow more of the x-rays to pass through. The densest material that's found in the body is the bone, and then followed by fat, soft tissue, and then air. We also have the densest material that could be seen on a radiograph would be metal, and it would just be stark white. So it would be even more radiopaque than the bone itself. This is actually showing a barium contrast study of the esophagus, and this is as the barium slug is going down through the esophagus right here, and you'll notice that there seems to be a narrowing right here, and that's because there's actually a tumor. So this is actually the wall of the esophagus right here, and right here. And as the barium then passes on into the stomach, then you can actually see there's irregular folding in this area. And again, the wall of the esophagus is actually right here. And so this is where this tumor is located in the esophagus itself. And we couldn't see that just on a plain film because the esophagus would take on that soft tissue opacity and not be able to be seen very well. This is an intravenous pyelogram, and this is actually showing the bladder and the contrast coming down from the kidney in the ureter. The intravenous pyelogram, we actually will inject the contrast into the cardiovascular system through an IV, and the kidneys will filter it out of the blood. And so it will highlight the kidneys. But then it will come on down the ureters and enter into the urinary bladder. So we get a good view of the entire urinary system. And if you notice right here at the arrow, you can almost kind of make out, it almost looks like a little small marble. That's because that is a kidney stone that is trying to pass through the ureter and causing a major obstruction right there. And I can guarantee you a lot of pain for this patient as well. Now, computed tomography or CT scan or the old term CAT scan also uses X-rays in order to take images. But what CT differs or how it differs from plain X-ray films is actually simply this. It takes a three-dimensional image of the patient. So radiation detectors record the amount of X-rays or ionizing radiation absorbed by the body and feed that data into a computer that reconstructs that data into a three-dimensional image for us. Again, radio-opaque and radiolucent tissues will appear white and dark consecutively, just as we saw on the conventional radiograph. And individual organs, however, are sharply demarcated by planes of fat that appear darker because of their lower density than the other soft tissue. And so CT actually gives us a little better view of some of the internal organs than just a plain radiograph would do for us. However, CT does deliver a higher dose of ionizing radiation than plain radiographs. So why would we want to use CT scans? Well, it can screen for cancers in asymptomatic individuals. It can detect abnormalities in internal organs that cannot otherwise be identified by standard films. And so this is actually a CT scan of the chest. And because this is all entered into a computer, I can get different views. So I actually can see a three-dimensional view. The way that the CT scanner works is it actually rotates the X-rays around the patient. And this is what gives us our three-dimensional views. And so then I can manipulate the computer to change the view. We are actually looking at a transsectional view here through the thoracic cavity. This is the heart. This actually is the aorta right there, that nice big round thing. This is the vertebrae right here. And you'll notice that the bone is still very opaque. And the lung fields, however, are really radiolucent. These are actually some of the blood vessels. But this little spot right here, it's very round, is actually an early cancer in the lung. Now, MRI. MRI is magnetic resonance imaging. Instead of using X-rays, what we're going to use is a magnetic field. And the principle is that, again, a computer will construct images of the body based upon responses of hydrogen protons in the water of the body when placed in a strong magnetic field. If you remember, hydrogen protons are positively charged. And so in the body, they will actually align in such a way that the MRI machine will create this image based upon these hydrogen protons actually aligning within the fields of the body. So they align in a particular direction within the magnetic field, attracted to the negative end, and yet this magnet is spinning all the time. And so these protons are following the spin of the magnet. So the hydrogen protons will temporarily be dislodged and wobble when the radio frequency waves are directed at them, and this is what then the computer will be able to see. These protons will emit a measurable signal or resonance as they're wobbling, and that can be used to construct the images. The intensity of resonance depends upon water content of the tissues, the strength and the duration of the radio frequency pulse from the MRI machine. So here is a normal MRI of a person's brain, and this is done in a sagittal section. So just to get you oriented here, this is actually the tongue. There's a tooth right there. This is the nasal passages, and it's pretty much right on the midline, so we actually see the vomer in there. The bone is still visible, but the nice thing about MRI is it gives us much greater detail of the soft tissue. Here you can actually see the gray matter of the cortex, the white matter here of the corpus callosum and the brainstem. You can actually see the pons right there. This is the cerebellum, foramen magnum in the skull. And again, we can see sinus passages in here. This is the sphenoidal sinus. This is the ethmoidal sinus, the frontal sinus right there that are air-filled. So we're still seeing that contrast, but we see a lot greater detail of the soft tissue. So if I'm wanting to look more at soft tissue structure, I'm probably going to choose an MRI over either plain X-rays or CT scans, if we can do it. Now, if the person has a piece of metal in them, you cannot use MRIs. because that metal will actually resonate within the magnetic field as well and can actually cause harm to the patient. It's not going to rip something out of you, but it's going to cause distortion, and that's going to be a problem. So, advantages of MRI over CT scans. We don't use ionizing radiation, and that is a big concern. It can detect abnormalities in tissues surrounded by bone, such as the spinal cord, the bony orbit of the eye, or even within the skull itself. Bone interference with scanning or interferes with scanning because of its density, but does not produce an image in MRI because of its low water content. So uses of MRI are going to include things like multiple sclerosis. It's much superior to straight mammograms in detecting breast cancer, and certainly others as well. Another type of diagnostic test is the PET scanner, and this is positron emission tomography, or PET. This actually assesses biochemical functions primarily in the brain, but can also assess metabolic activity of different organs or tissues. This is very site-specific in an organ where a compound is actually being metabolized. It can evaluate changes in blood flow in heart muscle following a heart attack, and can distinguish between benign from malignant tumors where there's increased glucose uptake in malignant versus benign tumors. The principle behind PET scans is it measures the metabolism of biochemical compounds that are labeled with positron-emitting isotopes to measure organ function. One example of this is glucose. Disadvantages of PET scanners is that, one, they are very, very expensive and not widely available, and they require facilities for incorporating the isotopes into the biochemical compound. So these are not real common even yet as of today. But this actually shows one of these PET scans, and the color represented here in the PET scan indicates distribution of a particular labeled glucose that's metabolized in a splenic tumor. This is a lymphoma within the spleen, and this is the spleen, and this is where the tumor is located. And you'll notice right here that there are mediastinal lymph nodes actually involved as well. So we've had a metastatic tumor movement through from the spleen into the surrounding lymph nodes. Radioisotope or radionuclide studies actually can evaluate organ function as well by determining the rate of uptake and excretion of radio-labeled isotopes. Uses of this would include anemia, where we can use a radioisotope labeled vitamin B12 that's necessary for hemoglobin production. Hyperthyroidism, which is using radioactive iodine, which is one of the most common things that we use radioisotope studies for. Pulmonary blood flow, we can label albumin to detect the presence of blood clots. And cancer spread, we can use a radio-labeled phosphorus to determine the presence of tissue deposits in bones or in the spine. And we can even evaluate heart muscle damage by evaluating blood flow within the coronary artery. This is actually a radioisotopic bone scan of the body, and you'll notice that anywhere it's really, really dark, we've taken up that radioactive isotope. And so where we have a lot of metabolic activity is where we're going to see that darkness. And so where these arrows are pointing are actually areas of bone cancer. We can also use cystology and histology as diagnostic testing, actually looking at the cells and the tissues themselves. Such as, for example, Papilloma, good luck saying that name, that's why we call it a pap smear, identifies abnormal cells in fluids or secretions for recognizing early changes that may be associated with cervical or other reproductive cancers in females. Biopsies, we can actually take tissue samples obtained for histologic examination to determine abnormal structure and cellular patterns that accompany particular diseases. such as in the liver, the kidney, the bone marrow, even the skin. A lot of times I will take biopsies of skin lesions simply to find out what is going on in the skin. We can also look at electrical activity through certain tissues, and this will test and measure the electrical impulses associated with body functions and certain activities. And you're probably familiar with the ECG or EKG, the electrocardiogram. This will measure serial changes in electrical activity of the heart in various phases of the cardiac cycle. It identifies disturbances in heart rate, in the rhythm, and abnormal impulses that may be seen in the muscle of the heart. It can recognize heart muscle injury from ECG abnormalities, especially after a heart attack has occurred. The EEG, the electroencephalogram, measures electrical activity of the brain. This is actually looking at the 4 different types of brain waves that we see: the alpha, the beta, the delta, and the theta waves. Alpha waves are seen in an awake but not really active adult. In other words, you're kind of zoned out and just sitting there, but you're awake. Beta waves are what we call sensory evoked waves. Most of you right now probably have alpha waves. You've been sitting here listening to me drone about this stuff, and now you're just kind of checked out. Well, wake up. The beta waves need to be engaged at this point because your actively sensory involvement is supposed to be occurring. Theta waves and delta waves are primarily seen in sleep. If theta or delta waves is seen in an adult that is awake, it typically shows extreme brain damage. Alpha and beta waves are both high frequency, low amplitude waves, whereas theta and delta waves are typically high amplitude but low frequency waves. EMGs, the electromyogram, will measure the electrical activity of skeletal muscle during contraction at rest. This will allow us to see, is there electrical activity actually occurring in the muscle, and may actually give us an understanding even of the nervous function that is linked to the muscles themselves. Endoscopy can be used to look at internal structures, especially of the GI system, but also may become invasive and look at internal body cavities. So we can examine the interior of the body using rigid or flexible tubular instruments that are equipped with lenses and light sources, and even sometimes channels for instruments that we can then utilize for doing surgical procedures. And so we can perform surgery that was formerly done through very large abdominal incisions through very, very small openings now. The bronchoscope can look at the trachea and the major bronchi. The cystoscope is looking at the bladder primarily. The laparoscope is primarily used in the abdominal region. And of course the colonoscope is used in the colon. Ultrasound is a very non-invasive procedure. It is mapping high-frequency sound waves that are transmitted into the body, and the echoes then reflect changes of the tissue densities and bounce back and are captured by the ultrasound machine. It's kind of like sonar that we use to map the bottom of the ocean floor. And one of the more common reasons we use ultrasound is to look at a fetus in utero. And so this you can actually see is the face. Let me get my pointer up here. This is the face right here. There's the nose, the lips are forming, and the head. And there's the rest of the body. This is actually the edge of the amniotic sac. There's the umbilical cord. And so we can actually look at structures. These are actually ribs right there in the thoracic wall of the fetus. Now, treatment. Why do we want to treat? Well, we want to make our patients better. So if we can treat, we want to treat. Specific treatment is going to be aimed at getting rid of whatever's causing the disease. Let's get rid of the underlying etiology or cause of this disease. whereas symptomatic treatment is sometimes the only viable option we have, and that is simply to treat the symptoms and to make the patient feel better. It is not going to do anything to get rid of the underlying disease and may actually have no bearing at all on the eventual outcome of the disease. So, to end with, just a few things for your consideration. So, what are the underlying principles for these diagnostic procedures of X-rays, CT scans, MRI, PET scanning? Can you explain the requirements for an effective screening test? Can you differentiate between symptomatic versus specific treatment, signs versus symptoms? And I will just say, we're going to talk about this in a later chapter, but here's the main difference. Symptoms are what the patients feel. It's what the patients report. They are subjective. Signs are objective signs of disease. What this simply means is that we can measure them or an observer can see them. And symptomatic versus asymptomatic disease. Can someone actually have a disease and yet report no signs or symptoms? And that can be very true. There are many situations in which this can occur. It might be a carrier situation, or it may just simply the disease has not progressed enough for the individual to report signs or symptoms at the higher level. There may be things going on at the cellular level that they simply do not feel or are measurable at this point. And diagnosis versus prognosis. Why do I want my diagnosis? Why would I want a definitive diagnosis? Because then I can look at prognosis. Prognosis, as I said, though, is sometimes just the practitioner's best guess at the outcome of the disease. But that's based upon, again, the history of the disease, the history of the patient, and the practitioner's experience with this particular disease. So there you have it in Chapter 1. And so have a great day.